Hello all, Dr. Arshad from Medsyno. In this short video, I'm going to explain about one of the FMG's high-yield pediatrics topic, that is congenital diaphragmatic hernia, being tested in the FMGE examination for 2 times and INICET 1 time. First, we have to know the definition for congenital diaphragmatic hernia. If you break down the word, then you can know the definition. Congenital means some kind of defect which is acquired by birth. Diaphragm means diaphragm is the muscle which separate the thoracic and abdominal cavity. Hernia means because of the anatomical defect, the mass or the anatomical organ moving from one anatomical zone to another anatomical zone is called hernia. Here you can see this is the normal diaphragm. Because of the defect in diaphragm, intestinal bowel loops are moving from abdominal cavity to the thoracic cavity. This is purely an embryological defect. Because of that, we are dividing into two types. One is the Bogdalek hernia, another one is the Morgagni hernia. This Bogdalek is the most common type of congenital diaphragmatic hernia. In FMG exam, they might ask what is the reason behind it. This is occurs due to failure of closure or maldevelopment of pleuroperitoneal canal or pleuroperitoneal folds or pleuroperitoneal membrane. So these three things denotes the same structure. This is usually on left and posterior lateral side. Another one is Morgagni hernia. This is due to failure of the retrosternal part of septum transversum to develop properly. It's over here. This is usually occurs on anterior and right sided. Now we have to know pathophysiology behind it, one of the most important one. Here, as you can see in the image, intestinal bowel loops are entering into the thoracic cavity. So abdominal organs enter the chest cavity. That leads to compression of the lung tissue. Compression of the lung tissue will lead to pulmonary hypoplasia. Pulmonary hypoplasia will lead to increase in the vascular resistance of the pulmonary, increase in the pulmonary vascular resistance. That leads to pulmonary hypertension. Pulmonary hypertension will lead to right to left shunting through patent ductus arteriosus. That leads to severe respiratory distress after birth. In short words, abdominal organs entering into the chest cavity that leads to severe respiratory distress because of the compression of the lung tissue. Just remember that. Clinical features of this diaphragmatic defect, we can find it through antenatal diagnosis of 20-week anomaly scan. After birth, just remember intestinal bowel loops are compressing the lungs. That leads to severe respiratory distress. When there is lack of oxygen, that leads to cyanosis. To compensate that, there will be tachypnea. This image mentioned over here, this is called scaphoid abdomen because all the bowel loops are enter into the thoracic cavity. So the thoracic cavity look one step above from the abdominal cavity as over here. This is the real case of congenital diaphragmatic hernia, the image I attached over here. Next, we have to know the X-ray finding they might test in the radiology. Just remember, there will be air-filled bowel loops in the thoracic cavity. In FMG, they will give air bubbles or bowel loops in the left hemithorax. Management. Management can be two types. One is the initial management and another one is the definitive management. Initial management, the main goal is we have to give the required oxygen to the baby and we have to relieve the lung compression by the intestinal tissues. The initial management is endotracheal intubation, nasogastric tube insertion for decompression and mechanical ventilation. This question they asked in one of the previous FMG paper, that is what we should not do. We should not do bag and mask ventilation in this case. Why we should not do bag and mask ventilation is bag and mask ventilation cause gastric distension that leads to worsen the lung compression, that leads again the severe respiratory distress. So that's why we are not using bag and mask ventilation in these cases. The definitive treatment is surgical repair of that diaphragmatic defect. So this is one of the previous year FMG question. In this, they already suspected this is the case of congenital diaphragmatic hernia. In this question, they are asking what is contraindicated in this case. In this case, the bag and mask ventilation is contraindicated as the explanation I gave you before. Second one is the X-ray feature they gave over here. X-ray revealed multiple air-filled bowel loops in the left hemithorax, and then because of that, mediastinal shift is there. So this is also the case of congenital diaphragmatic hernia. So this is one of the high yield and easiest topic. Just to understand the bowel loops are moving from here and there, and just remember the embryologic defect which I mentioned. So that's all. If you need any help regarding FMG, please feel free to contact me. I will be happy to help you out.